Consider This with Carol Schrader is made possible with support from Bass & Associates, First Data Resources, and by Nebraskans for Public Television. Consider This with Carol Schrader, a news and information program recorded on the campus of the University of Nebraska at Omaha. From the Fireside Lounge in the Milo Bale Student Center, here is your host, Carol Schrader.
Talking to my guest, I'm so excited. And anytime I think that they can take care of the things that I get every year, this time of year, I get excited. We've had a lot of false hopes, but this one sounds like a keeper. Please meet my guest today, Dr. Jose Romero. He's an associate professor of pediatrics, pathology, and microbiology at Creighton University and the University of Nebraska Medical Center. And I'll admit it, I got you out of the paper. The World Herald carried an article this week that you were working on testing a drug called Pleconazole.
That's correct.
And that the FDA hadn't approved it, but it gets the common cold. You know the old joke? It's hard to cure as the common cold.
That's right.
This is exciting news.
Yeah, I think you're right. I think it's opened up a new realm of therapy for a very common group of viruses.
Now, it's a virus that in itself most of us survive very well, but even the common cold can be dangerous for some people. So it's not just a matter of convenience. Oh, gee, you know, I'm going to put out a little bit because I've got a cold.
Yeah, the cold actually in itself can have some complications. So having that agent available to treat this Pleconazole, to treat that, is certainly beneficial. Patients lose a lot of time from work from a cold, and that's another major impact that this will have is on days lost from work, and you know the health, the economic impact of that in itself.
What's with these viruses? From the time I was studying biology in high school, I learned that a virus is a very different thing than a bacteria, and it is. Sometimes you'll read about it that it's older, an old life form that can evolve so quickly that it's going to long outlive
Right.
live us, although it needs us in some cases.
Right. Unlike bacteria, viruses in themselves can't multiply. I mean, they need something else to multiply, and that means that they need a cell, and that's how they get transmitted from person to person. Without that person, they're not viable. Viruses have probably been around for a long time. They're specially adapted. They're very adapted to certain types of people, so that these viruses only affect humans and they don't affect animals very well. So they're very adapted to humans. They're simply a case for carrying around genetic material. That's what a virus is at best.
Well, you know, when you say it like that, it sounds like something we should be able to just take care of like that.
Easier said than done.
But they are mysterious.
They are. They're extremely adapted to evading the immune system and pirating the cell machinery to make copies of themselves.
It sounds like a computer.
It is. It really is. I mean, it's like inserting computer code and having it do what it's supposed to do. It will take over a cell completely.
Well, let's talk specifically about it. And I don't want to get too technical, and I know that you will understand the fact that my mind can only comprehend so much. So, but the common cold is a type of virus that has eluded us, as many viruses have. But what is it about? Now, what's the type of
Yes.
Pleconazole?
Very good. We look at viruses as families. So the family of virus which this belongs to is called the picornaviruses, which means, the name means small RNA viruses. And in that family are a lot of other viruses, other groups of viruses called genuses. In those groups are the rhinoviruses, which cause the common cold, and another very important group of viruses called the enteroviruses. And the enteroviruses, the major players in that include poliovirus, for example, the Coxsackie viruses, the echoviruses, and the numbered enteroviruses. And those viruses tend to cause meningitis and other diseases of almost every organ in the body. But meningitis is the big disease that they cause.
So am I leaping too far to say that if you can find one that can cure this particular rhinovirus or the common cold virus, that you're unlocking doors to other viruses in the same family?
You're exactly right. And actually, Pleconazole has been shown to be effective in the treatment of aseptic meningitis in adults. and in children also. The data is out there now that in adults it shortens the disease. And in children, the studies have indicated that there is a trend towards significance. We hope that this year's studies will answer that question definitively. And if that's the case, we will have a treatment for aseptic meningitis, hopefully.
Well, that is talking about life-threatening or at least debilitating.
Very much so. Very, very much so. And so it's a drug that opens up a lot of possibilities. Investigators all around the world have been using this agent now. We've gotten a lot of experience with it in both adults and children.
Okay, what's the drug company?
It's called Viral Pharma. And they're
smaller company or a bigger?
Smaller company. They're almost exclusively dedicated towards looking at therapies for RNA viruses, and they've been around for about 5 years.
Well, obviously, there's so many ways I can go here. It's going to be hard to keep me on one track. Obviously, somebody came up with this, and when you have a virus or a pathogen and you are looking at a class of chemical combinations, I mean, was this something they came up with, some researchers just sort of put together, or is this something they've been working on for a long time?
They've been working on it for a while, and you started with a certain class of drugs and then modified them as they went on. They found better and better drugs, and this is, I'm sure, just the beginning of a number of compounds that will be coming out. It really is novel because unlike a lot of the other drugs that are used to treat viral infections, this one actually binds to the surface of the virus and keeps the virus from opening up and actually getting into the cell or even attaching to the cell.
Because I remember the little you laugh at me, but the little film strips we saw about viruses that they would kind of crack open and spill out their little RNA guts.
I think I saw the same ones that you saw. Yeah, it's actually very interesting as to how they can do that. It's not, they don't crack open like eggs. We're learning a lot more about them now.
I know, but
essentially
it was the picture that was painted in my
right,
mind.
and essentially that's the easiest way to remember them, is that they do crack open once they get on a cell and insert their genetic material. And this drug actually stops the virus from opening up and getting inside. Most of the agents that are currently available now require that the virus be inside the cell, and then they work. So this actually prevents it.
Which means they have already invaded
That's right.
the cell and can already do some damage and maybe on spurring new damage before you've actually destroyed the virus.
Right, and certainly patients that have colds, the rhinovirus infections or enterovirus infections, are going to have the virus already multiplying inside of them, and that's really important, I think, to talk about later on. But what this drug will do then will be to bind to the virus even before it gets in there and keep it from getting in.
So we've got a new kind of drug or a new class of drug, and is there, when you say that it can help meningitis and some of these other things, these rhinoviruses, but this binding thing, is this you said is a whole new kind of a new concept or a new?
It's a new way for these drugs to work. Again, most of the drugs that we currently have inhibit the virus from making the genetic material. This actually prevents the virus from getting inside the cell. So it's another mechanism of working.
Would it be easier to bind to the outside as opposed to having to slink in? Or is it just a whole different concept?
It's a whole different concept, but in theory you could say yes. I mean, you don't need to have the virus actually multiplying for it to be inside the cell for the drug to interact with it. So if it's in the environment and the drug is floating around in the environment with it, it can latch on to the virus and keep the virus from opening up.
You know, the past several years we've heard a lot about antibiotics and how we are becoming, several things are becoming resistant to them. Tuberculosis is one that comes to mind. There are many other things, but you know, how we don't take them properly and we overprescribe them, and the bacteria have evolved and just enough to dodge the bullet. Do viruses work the same way in how they evolve or how they learn to trick?
Most definitely.
So
most definitely.
We'll still have the same hurdles to go down the road.
Yes, and I think that's a very important point that you're bringing up here, that this is not the end-all and be-all for therapy. You know, viruses will evolve. That's the nature of them. They're genetic material, and especially RNA viruses. They're sloppy and they make lots of mistakes and evolve quickly. And so,
never thought of them as sloppy. I've thought of them as a lot of other things.
But the issue is that we will have to be careful about who gets this drug and when it's indicated. I mean, this is clearly not a drug that should be given to patients that have influenza. It's indicated for patients that have the colds. You're not going to use this drug to treat bacterial meningitis because it has no role in the therapy.
However, You have witnessed as a doctor, maybe with some chagrin, over the last 3 years, the incredible whole new onslaught or the whole new attack on consumers with advertising that has created. First, we had the phase where I need an antibiotic. You know, you get something, it's a cold, anything, and you know, you call up the doctor and you go, I've got to have something. The doctor feels compelled to give them something. We reached that point where we were conditioned to get something. Well, now, not only are we getting something, but we're calling our doctor up and asking for them by brand name. I want Tamiflu. I heard that's going to cure my flu. Well, I don't know if you have the flu. You know, this whole kind of game. And I know many doctors that are saying we have to kind of take a break. And because of the evolving process, we are going to have to make sure that you don't have pneumonia when you want an antiviral and so on. You've got to wonder about where we go with this and if we could just be kind of propelling the evolution of these critters.
Yes, if you're using it in an indiscriminate manner. And again,
But you know it is.
But it requires that the physician examine their patient, and that's really where the...
Have you tried to get into the doctor during cold season?
I understand that. But again, it's the responsibility as a physician, and I'm a practicing physician. I am
Right.
not just a bench researcher and a clinical investigator. I'm a practicing physician. And I view that as my responsibility before I prescribe an antibiotic or an antiviral, that I examine that patient. Yes, we realize that in certain times of the year, the clinical load is very heavy, and allowances have to be made for that. But again, you are correct. If we're prescribing this over the phone without examining the patient, then we're driving the problem forward. And it's not the patients that are driving the problem forward, it's the physician. Because they can ask all they want.
But then you shop around.
But
I mean, you know how this is, what this has turned into.
Again, it's the same issue. It's the physician that's driving. They can call, the physician should say, no, I need to examine you and make that decision based on the physical exam or the laboratory test. Again, the patient can call as much as they want. It's the physician that prescribes. So we the physicians, are ultimately the gatekeepers of these resistance problems. And we have to decide when it's appropriate to use it. And the other issue, I think, Carol, is that we have to educate the members of our community. That is, how to tell the difference between a bacterial infection, the flu, and the cold. And now that becomes very important because we have multiple agents available for, as you said already, the treatment of the flu. There are 2 agents available, Tamiflu and Relenza. And now if there's an agent out there to treat a cold, physicians and healthcare providers have to understand the difference between what really is a cold, the flu, and pneumonia. And they can be separated clinically if you ask the right questions and examine the patient.
One of the things that I know is that we're running away and getting all these great drugs, these medications, and that's a terrific thing. But are we caught up in terms on the end of testing? There are some things that you don't know if someone's got strep throat or if they have a cold or the flu, at least at some stages. And so, you know, they give you there's the quick strep test and there's the unquick strep test. And are we keeping up and being able to diagnose properly so that we can use these drugs and meet the needs of the pressure from the patient? And obviously they want to get better and could get pneumonia or, you know, some secondary infections.
Sure. In certain areas we do have very good tests. For example, the rapid strep tests are good, and if those are negative, then you always follow them up with the not so rapid strep tests, as you were talking about, the old traditional culture. For influenza, we've got some tests out there. There are some problems with it. But in a community, for example, where we know that there's influenza circulating, so the medical centers, both University and Creighton and Children's Hospital, all keep running logs of what viruses are in the community. And we know when influenza is in the community. So if you come to me and say, I have sudden onset of headache, fever, muscle aches, and I've got a cough, you probably have the flu.
And I want to basically just crawl in a hole.
Right, exactly.
Yeah.
And in that case, and you don't look like you have any other signs and symptoms of a bacterial infection, you have the flu, I probably don't need to do any tests on you, and I can treat you with whatever drug I prefer to use.
You've got a high probability of hitting it. Yeah.
That's right. On the other hand, if you come to me and say, you know, I've got a little bit of a scratchy throat.
Which I did before this show.
Little sniffles, and I'm feeling, you know, a little tired and a little achy. I'm going to say, you know, I really think you probably either have a cold, a rhinovirus, or some other virus, and you definitely don't have the flu at this point based on that, and you most definitely do not have a pneumonia. So in that case, then one of these other agents, if they're ever available or when they're available, would be indicated for you. We don't have good tests for making rapid diagnosis for the mass public for rhinoviruses right now. There are some very specific tests, and actually University of Nebraska Medical Center is one of the tests that can run these, centers that can run these very specialized polymerase chain reaction tests to make the diagnosis rapidly of enteroviruses. So, we will be able to administer this drug to the right patients because we have this assay available to us very quickly.
Now, correct me if I'm wrong, I'm really going on a limb here because I hadn't thought about it before the show. Don't young children, because you're a pediatrician, get kinds of rhinoviruses that are really hard on them? I mean, different kinds. I mean,
more so the enteroviruses. The children and infants in particular are the ones that really show up with enteroviral aseptic meningitis. We know that adults get it too. The CDC has estimated that each year in this country alone, there are 30 to 50 million enteroviral infections. That's enteroviruses, not the rhinoviruses.
Oh.
And so there are somewhere, it depends on who you listen to and what you're reading and how you do the math, there's somewhere between a minimum of 50,000 to up to 300,000 cases of aseptic enteroviral meningitis a year. So it's very common. It's a summertime virus, and if you go to our hospitals in the summertime, many of the children that are being admitted for evaluation of bacterial diseases really have enteroviral infections.
So this is significant if this plays out for them, for our children.
I
this is
definitely think so. And
not
also,
just our convenience of, well,
that's just one aspect of it. I think that the colds is one aspect, and this other aspect is the aseptic meningitis. There's another subgroup that's also going to benefit from this, I think, if the studies continue to progress the way that we think they will. Enteroviral infections in the newborn can be very lethal because they can't mount a good immune response.
Virtually none in those kinds of viruses.
That's correct. And the worst case scenario is where the mother has recently been infected with enterovirus, and she may have a mild syndrome, or sometimes they even have severe disease, and the baby is delivered within a day or two. In those cases, the baby received no antibodies from the mother, but received virus instead because the virus is circulating in the blood. Those babies essentially are overwhelmed by the virus, and they can die or be left with very severe problems. This drug is currently being looked at as an agent for the therapy of those infants. And it's the first time that we may have something really substantive to offer them with regards to therapy.
And that's devastating.
Mm-hmm.
I mean, any death is devastating, but I think we all have an empathy for that special problem. Well, what about, you said that the polio is an enterovirus. Mm-hmm. We don't think of polio as being a problem.
It's not anymore, thank God, and that's because of the vaccination efforts that we've had. As you probably know, and many of your viewers know, polio has been eradicated from the United States and from the Americas for close to 20 years now. And so the issue has been that in this country now, we've really not thought about polio. In other parts of the world, it's still a problem. And we hope to have polio eradicated sometime in the next 5 to 6 years, similar to what we did with smallpox.
But in certain third world countries primarily, it's not mass vaccination isn't. They're having trouble getting other basic
That's right.
Health issues taken care of.
The World Health Organization is really pushing for this vaccination. I think that it may be possible to eradicate it. I mean, we have been one of the groups that have looked at the therapy of poliomyelitis with this drug, and in our hands we've had a good outcome. We've actually been able to eradicate polio from the spinal fluid of a child that was immunosuppressed and had a poliovirus infection.
Wow.
So we have the data that shows that the virus was no longer present after starting the antiviral drug pleconaril after a few days.
Well, obviously you're not done with pleconaril. You've got other, I mean, some research projects, have a start and a stop date. Are you doing ongoing research or data taking with this?
At this point, all of our studies are closed at this time. We will be probably reinitiating studies in the spring as enterovirus season comes up. The compassionate release program is always open, and there are certain cases where we would consider using this. If you had certain types of heart disease or very severe forms of meningitis, we could certainly get a hold of the drug, or even neonates that have infections.
And I wasn't aware of that. that is something that when you have dealt with the drug and you know how to use it, that you're able to do certain things with it?
For almost every drug, there's a compassionate release program, and that is a compassionate use program. And that's usually run through the company itself and with the NIH and your IRB. And so cases are looked at individually, and the risk-benefit ratios are looked at very closely. And if the risk of severe disease is far greater than any possible risk for use of the drug, if the patient agrees and if there's informed consent and the IRB and everybody's comfortable with it, we will sometimes use a drug.
When do you think this would be available? How much more of the process does it have to go through?
You know, I really don't know. We think that it may go up for FDA approval at the end of the year, and hopefully by the beginning of next year we'll have the agent available
like
for
cold season.
Yes.
The end of next cold season. When we talk about viruses, going to get back to the more general area, and this isn't your area, but we certainly are overwhelmed with things. Comes to mind, and it's not this kind of virus, but AIDS. I mean, just the whole viral problem, the big ones out there. And every virus can do damage. But you know, what are our hopes for vaccinations versus cures versus how far do we have to go? How many questions still need to be unlocked and answered?
I guess for HIV, the issue is probably still quite a ways. The virus is an
What makes it different?
It's a virus that, like the RNA viruses, I mean, it is an RNA virus, and it can mutate very quickly. And that is a very important issue, is that if it can change different parts of itself and to evade the immune system, it's going to survive longer and be more difficult to make a vaccine against. The viruses like the picornaviruses can mutate, can change, but there are parts of the virus that have to remain very stable in order for it to continue to live. And that's why we can make a vaccine against polio, for example, because the capsid, the shell, can't change that much. HIV is one of those viruses where you can change different parts of it and evade the immune system.
And basically we could probably annihilate most of them, but we'd annihilate ourselves. I mean, it's a fine line,
That's right.
isn't it?
Many of these agents are also very toxic to the human body because they work at a level of RNA or DNA replication. They're copying the genetic code. And it's very hard to make selective agents that work only against the enzymes that are used by the viruses. This drug, pleconaril, seems to be very safe because it doesn't seem to work on anything in the human body right now.
You obviously became a physician because you had a desire to help people, make them feel better, or you were fascinated by disease and how it works and everything. But what kind of you like working with your patients, I can tell when you talk, but what kind of a rush do you get when you work on the research end of it, a drug investigation as opposed to the clinical research? You're lucky, you get them both.
I actually get all three because I actually get to do bench research. So we actually do molecular virology in my laboratory. I'm very lucky. I mean, I get the best of all three worlds. I mean, I get the best of the clinical end, the clinical trials end, and the basic science end of it. Each of them has this wonderful feeling of seeing something new. So, for example, when you're dealing with a new drug, it's this prospect of being able to offer this to a large population of individuals and to really make them feel better. For me, the enteroviruses have always been something that I found interesting, even as a resident, because we would admit these children, we would have to rule out bacterial disease, and then once we rule out the bacterial disease, what did we do with them?
Yeah.
And I became interested in the enteroviruses primarily as in the aspect of diagnosis, and then eventually moved on to the issue of why they cause disease. And this actually being involved in clinical trials was a bonus. I never thought I'd be able to do this, and more so to be part of this company that actually is making headway in this area. So it's a wonderful feeling.
You're an import. You weren't homegrown.
That's correct.
You work both at Creighton and at UNMC. You do your research, this particular research at UNMC. Omaha tends to go through these identity crises now and then. Is the medical atmosphere good for research in Omaha?
I think it's okay.
What could make it better?
I think that if we need to focus a little bit more on certain areas of key excellence. I mean, we can't be good at everything.
Right.
And I think that's an issue. I think the public should take pride in these research institutions. We have some very good people here. And I think if the public got behind these institutions and supported them, I'm not sure exactly how. Financially is one way. You know, we could certainly go much further than we have already. We certainly have the substrate here to become a major powerhouse in certain areas.
We hear when we look both at just our regular universities, not the medical centers, but we keep hearing that in the sciences and everything, we really have to invest some,
Yes.
and that's the first backbone,
Yes.
and then you have the next layer in specialties like medicine. And we're you know, then we have governors that, and I'm not blaming Johannes, but we have our lawmakers or whoever that come in, you know, they're supposed to hold the line. I mean, you understand. How do we make people understand, you know, where you're coming from, of attracting the best and the brightest?
I think it's important to key in on these issues, these small accomplishments that we do here, so the public can see the benefit of them. It's hard for somebody to understand why we would look at a particular gene if there's no long-term implication for it. You know, if you're studying the gene of one of these viruses, which we do, I mean, what's the long-term implication for human health? Well, there may not be any direct implication at that point.
And not now, but it might
in the
combine with
future.
something
And
else.
That's exactly right. And
you
that's
know,
where people like you and shows like this actually serve the public, because they see that this research, that really the understanding of this virus, the ability to make this drug, came from the basic science work that was done decades ago. And so understanding this virus, understanding how it's put together, what the nooks and crannies of the virus are, allowed these researchers to develop this drug.
and the synergism of people working on similar things, one little gene, all in different
It
places.
all comes together.
And then that information being traded is...
Right. One of the reasons why we were able to get a rapid deployment against HIV was because some of the compounds that were out there were already out there for therapy. They just weren't used. And then they found their use for this particular virus. And so this idea of having directed research may not be the best way to go. You have to have freedom to explore these issues. And many times the public doesn't understand that. And that's where we have to convince our legislators that this is an investment in our future. And really, you hit the nail on the head. You have to invest in this. You have to put the money into the institutions. Without the substrate to begin to attract young physicians, young investigators, and keep them here, okay, they're not going to stay. And once they make a name for themselves, they're going to leave. You're going to get the brain drain, because places like Stanford, Harvard, Yale are going to draw them away.
We want to congratulate you on your work with Pleconaral, and I'll be waiting to ask for it and ask if it's appropriate. Remember, research is in its infancy in terms of the length of mankind,
That's
and
right.
so we have a long way to go. Thank you, Dr. Jose Romero, and thank you for joining us on Consider This.
Consider This with Carol Schrader is made possible with support from Bass & Associates and First Data Resources.